You don't need to be combining therapies that are the therapies that are available. You can use them by themselves for morning sickness. So that's a clarification. And also another clarification in terms of the disease states that we're covering for this course. Second generation antihistamines are what you should be using for all the disease states we're covering in this course, except for nausea and vomiting. So for like insect bites or for allergic rhinitis, second generation antihistamines are what is recommended. So for like insect bites, because you can use an antihistamine to help with the itchiness, an oral antihistamine to help with the itchiness. But that is the second generation antihistamine, not the first generation antihistamine, because the first generation antihistamines have those side effects like dizziness, drowsiness, stuff like that. So I just wanted to make that clarification before I begin. So the first question that we have is LF is a 26-year-old male who is finishing up his studies in pharmacy school, reports intense bouts of nausea but no vomiting before his exams, drinks 6 cups of coffee, sorry, that's a typo, a day, as he studies before his exams and sleeps less than 5 hours a night. He has a routine of meditating and listening to calming music, which he finds helpful but still feels nervous before exams. He reports no medical concerns and takes no medications. Which of the following recommendations is the most appropriate? So I have highlighted the pertinent things. So because case-based questions do tend to have a lot of information presented, something that you can do that might be helpful is to use the highlighter function in ExamSoft to highlight the things that kind of stick out to you, so that when you're looking at the information, you're really just focusing on the things that are most pertinent to making the best, to choosing the best answer. So I've highlighted that he has nausea but no vomiting, drinks a lot of coffee a day and doesn't really sleep very much at night, and he like has tried some lifestyle things, but he feels nervous before his exams. So this question is really just asking about lifestyle things or non-pharmacological things that the student can do or the patient can do to help reduce his nausea. So what type of nausea and vomiting would this kind of fall under? Or would best fall under so we have motion sickness, morning sickness or nausea and vomiting of pregnancy, viral gastroenteritis, and then upset stomach.
Upset stomach.
Yeah, perfect. So the correct answer was limit coffee consumption and stress, and then to kind of give you a rationale. So A is correct because it provides lifestyle recommendations for the patient's nausea and vomiting due to upset stomach. So it could be he might be feeling nauseous because he drinks so much coffee and he's very stressed. So those are things that he is undergoing and is pertinent to him that would help with his nausea and vomiting. B is incorrect. So taking oral rehydration solutions to avoid dehydration is incorrect because the patient's not vomiting, so he is not at risk for dehydration. He just feels nauseous. C is also incorrect because of the same reason. He doesn't need to eat a dry, bland diet because he's not like actually vomiting. And then wearing acupressure bands while studying would not be helpful because that is mostly for motion sickness, and it doesn't help with the underlying cause of the nausea and vomiting. Any questions about this question? Okay, so let me move on to the next one. So this is just to show you like the slide that comes from the lecture. So it's the non-pharmacological things that you can do. And so avoiding any disagreeable foods, for example, coffee, avoiding stress, those are, reducing stress, those are the pertinent lifestyle things that would help with that specific case. Okay, so the next question is EK is a 31-year-old female who is 9 weeks gestation and reports mild nausea for the past 6 days. She starts feeling nauseous soon after waking, and her symptoms are intermittent throughout the day. She has tried eating dry crackers throughout the day, which have been mildly helpful, denies any other medical conditions, and takes prenatal vitamins daily. Which of the following is the best recommendation? So what type of nausea and vomiting does this patient have? What is the underlying cause?
Pregnancy related.
Yeah, perfect. So I've highlighted the pertinent things that are most important that should stand out. So you know that she is of 9 weeks gestation and reports mild nausea for the past 6 days, which occur soon after awakening and are intermittent throughout the day. So it seems consistent with morning sickness or nausea and vomiting of pregnancy. She has tried some of the lifestyle things which were a little bit helpful, doesn't have any other medical conditions, so those things don't really pop out. And so in terms of the best recommendation, this would be pyridoxine. So pyridoxine can be used by itself for morning sickness. The other ones are not correct because taking Pedialyte is an oral rehydration solution, so it is to help with dehydration, preventing and treating dehydration, and the patient is reporting mostly nausea. So taking Pedialyte would not help with her symptoms of nausea. Pyridoxine is correct because vitamin B6 or pyridoxine is a safe complementary option for nausea and vomiting of pregnancy. And then loratadine is incorrect because that is a second-generation antihistamine, and the second-generation antihistamines are not helpful for nausea and vomiting. So only for the disease states we're talking about for this course, because like for insomnia, taking a first-generation antihistamine would be beneficial in those cases too. So just for the disease states we're talking about in this course, nausea and vomiting in terms of first-generation antihistamines, that is useful for nausea and vomiting. And the second-generation antihistamines aren't because they don't really cross the blood-brain barrier like we talked about before. So that's kind of like the exception. For the other disease states, you would prefer a second-generation antihistamine. And then the patient is reporting mild nausea. So her symptoms are mild, and so she does not need to be referred to her OBGYN. She could be managed with self-care. And she doesn't have any other self-care exclusions. Any questions about this question?
Dr. Cole, on slide number 25 of your handout, is complementary therapies camp, are they for pregnancy or for every nausea and vomiting?
So let me pull it up. So let me show you. So used for is kind of like what is mostly used for. So ginger is used for nausea and vomiting of pregnancy. Pyridoxine is used for nausea and vomiting of pregnancy. And acupressure bands, you can use that for nausea and vomiting of pregnancy, but it's mostly used for motion sickness. So for these complementary therapies, all three of them can be used for nausea and vomiting of pregnancy. However, acupressure bands can also be used for motion sickness.
Yeah, I put the answer, I know it's wrong, but the patient doesn't have hyperemesis gravidarum, like severe type of nausea vomiting.
Right.
But I looked at your slide, like when I was answering, like I was suspicious, like what to answer. So then I looked at slide number 22, and if you bring that please. 22. Then it says that doxylamine in pregnancy plus minus predoxy. So I thought that maybe you need to give it like together.
Okay, so this is only this slide on the first generation antihistamines is only talking about the first generation antihistamine. So for doxylamine, you can use it with or without pyridoxine. However, if you look at this slide, or actually let me go back because I highlighted it in the other one. This slide summarizes basically how you treat for each of the different underlying causes of the nausea and vomiting. So if you look at pregnancy with mild nausea and vomiting, you can consider vitamin B6 or pyridoxine supplementation with or without doxylamine. You can consider phosphorated carbohydrate solution, ginger, or acupressure. So if it has like a plus or minus sign, it means that you can use it with or without it. It doesn't mean you have to use it. Like if it has to be used together, then it would say vitamin B6 plus doxylamine.
Okay, so that is my mistake. Like I saw that doxylamine, based on that slide, doxylamine, when you put plus minus, like you can give, you can add vitamin B6 to that or not. Like, I don't know. It's not important, but thank you for clarification. I noticed that.
Okay, yeah. So, just to clarify, you don't need to use them together. Often they are used together, and there is a prescription product that combines the two of them. But for self-care purposes, you can use one or the other and see if it's helpful. And since that patient was reporting mild symptoms, trying one versus trying a combination product could be reasonable. But it's not like trying both would be wrong, but trying just the pyridoxine would be fine too, if that makes any sense.
Yeah, thank you so much.
Okay.
Dr. Cole, sorry. If this question, in this question, doxylamine was one of the answer choices, we would choose that first and then pyridoxine? Or which one first?
So you can kind of talk to your patient about it. There's not one that is necessarily like, so for some of these self-care disease states, there is kind of like a first line and then something to try next. For others, it's kind of like, these are all options that you can possibly try. So the reason why I didn't put both of them as options was because you could reasonably choose one versus the other. It really just depends on the patient. So if the patient really wants to avoid taking like a medication and prefers like a complementary option, then vitamin B6 or pyridoxine might be better for that patient. But if they don't mind either way, they could try doxylamine instead. So it kind of just depends on the patient.
Thank you.
Okay, so the next question is KG is a 27-year-old female who went, sorry, my screen is a little bit, I think I missed a chat thing. I can post these afterwards, the slides afterwards.
Thank you.
Okay. I think that's just a typo. KG is a 27-year-old female who approaches the pharmacy counter. She is complaining of itchy bites on her bilateral calves. Upon inspection, you notice multiple scattered and raised erythematous bumps on her lower calves that are consistent with jigger bites. KG reports that she went camping 2 days ago. Which of the following is the best recommendation to prevent these bites from reoccurring in the future? So I've highlighted the aspects of the case that are most important to consider. So basically, the first is that she has jigger bites. So we know, so what would this be considered, an insect bite or an insect sting?
Bite.
kind of gave it away a little bit, but yeah, so this is considered an insect bite. She went camping 2 days ago, and what she really wants in terms of the recommendation is to prevent these bites from reoccurring in the future. So that is a key aspect of the case to consider. Preventative measures for insect bites. So the correct answer is apply DEET 35% every 6 hours. And this is the rationale. So A is incorrect because applying ice 10 minutes on and 10 minutes off, that's a good way to treat the insect bites immediately after they happen to help relieve some of the swelling. But it's not going to help her prevent these bites from occurring in the future. The same applies for B. Petrolatum is to help reduce irritation of the bite, so that it can possibly help with reducing like the itchiness that the patient feels. C is correct because DEET is the most effective way of preventing insect bites. And just a reminder, DEET is not effective for insect stings. They are only effective for insect bites. So they are not effective for like bee stings or fire ants or wasps or stuff like that. And it's the frequency of use every 6 hours is appropriate because you just want to make sure that patients aren't using it more frequently than every 4 hours. So that's why it's the best option. And then D is incorrect because citronella oil is less effective versus DEET. If the patient like specifically wanted something that was considered like complementary or natural, then they could, citronella oil is fine, but the percentage of DEET, 35%, is safe. And as long as you're not using it more frequently than is safe, which is more frequently than every 4 hours, then DEET is safe. You don't have like a high risk for the like neurologic side effects that might occur. If you are using it excessively, that's when you would be concerned about that. And for children, you want to be a little bit more careful too. Any questions about this question? Okay. And then, so this is just from the slide. It comes from the non-pharmacologic prevention slide. So for prevention, there are different like lifestyle things that they could do, like making sure that they wear enough, like cover up exposed skin, avoid areas where those insects are, like swamps, dense woods, dense bushes. In terms of like different pests that pets can bring into the house, you want to make sure your pets are free of pests. Avoid standing water because that attracts mosquitoes. During dawn and dusk, that is also when insects are outside more often. And then using netting or window screens can prevent insects from coming inside the house. Sometimes in other countries that have concern for diseases that are transported by mosquitoes, you might sleep with like a mosquito net or something to make sure you're not bitten while you're sleeping. So those are all counseling things that you can recommend that are non-pharmacologic and for prevention. In terms of the differences between insect bites and stings, for only bites can you use these insect repellents because they're not helpful for stinging insects. And then if someone is stung and they have a severe allergic reaction, they should have some kind of a marker to let people know because it can be dangerous if they get stung again and they don't have anything to help, like an EpiPen or something. Okay.
Dr. Kong, I'm sorry, just a quick question, please. If you're choosing the antihistamine, so should we choose the second generation first before the first generation because of the side effect?
Yeah, so you should choose the second generation. I would say avoid first generation antihistamines for for the purposes of itching from insect bites. So if you have the option, and not even recommending the first generation antihistamines for insect bites, just the second generation. Okay. And then the last question that I have is, MB is a 46-year-old male who approaches the pharmacy counter complaining of dull pain from a burn he sustained while cooking about an hour ago. Upon inspection, he noticed a small red blister on his right forearm that is the size of a nickel. At home, he ran the area of skin under cool water and cleaned the burn. Reports that he has seasonal allergies and takes Claritin as needed. He is amenable to any therapy that provides the best pain relief. Which of the following is the best recommendation to relieve his pain? So I've highlighted the most pertinent aspects of this case. Dull pain from a burn about an hour ago. So you know kind of like the time frame. You know it's about the size of a nickel, so it's a pretty small area. He's already run the skin under cool water and cleaned it, so the burn is not infected or does not have any contamination. And he's amenable to what he is trying to find is something that provides the best pain relief. So because his BSA affected is less than 2%, you know that he is a self-care candidate. And the best answer would be Motrin 200 milligrams PO every 6 hours as needed for the pain. So for pain relief from a minor burn or wound, typically systemic therapies are recommended first. And if someone is not achieving enough pain relief from a systemic therapy, then you can add on or try a topical therapy. Or if someone prefers to avoid systemic therapies, then you could try a topical analgesic. And you can only use the topical analgesics for closed wounds. So the rationale is, so that's why A is incorrect. B is correct because it's an oral analgesic for pain relief. C is incorrect because the wound is clean and it's not contaminated. You don't need to use a topical antibiotic like Neosporin for most wounds if they're clean and they're not contaminated. If after cleaning you see some debris in the wound or something, then you can apply the antibiotic, but otherwise you don't need to apply the topical antibiotic. And the patient is a candidate for self-care, so they do not need to be referred to their primary care provider. Any questions about this question? Okay, so I think Dr. Cow, and then this is kind of like a summary slide to kind of better understand when you would use what topical product. I would refer to this slide because it kind of summarizes it in the third box for topical pharmacological therapies. Okay, so Dr. Cow, let me.
I can just stop your screen share.
Okay.
I'll just do that.
Here. Okay, I stopped it.
All right. So this is the right one, yeah? Okay. Can everyone see my screen?
Yes.
Yeah. Okay. All right. So let's go over the 6 other questions. The first one is a patient who has hypertension who comes to the pharmacy with complaints of decreased bowel movement frequency and bloating associated with constipation. This patient has been taking a fiber supplementation, but that fiber supplementation has not been completely helpful. I mean, it seems like the patient gets a little relief, but not satisfactory relief. And then which of the following would be the most appropriate agent to recommend next? So for those who have already looked at this question, what did you guys pick?
Pick
A, polyethylene glycol.
Yeah.
That is the correct answer. So if you remember from the slide, that for most cases of occasional constipation, bulk forming agent should be considered first line, which I think I've already emphasized a lot in the class. And your second agent is generally Marilax or polyethylene glycol 3350. Because once the patient is not completely responsive to the first agent, then you can start adding on second agent. Okay. Why is it not the other choices? So one of the choices there, I think, was Fleets, right? Fleets, I think so. What did I say? Fleets enema, Docusate, and mineral oil. So Fleets is a saline laxative, right? And the generic name is sodium phosphate. This is a product that you really need to be careful because of the sodium content. Patient with heart conditions, as well as patient with kidney condition, really shouldn't be using this drug. Specifically, this product, it's really shouldn't be used in patient with cardiovascular disease, so either heart failure or hypertension. So that makes Fleets enema not really the right choice for this patient. Docusate is an agent that I guess the patient could use in terms of like no contraindication or no precaution. However, because this is a stool softener, it is used primarily for dry, hard stool. And this particular patient, if you remember from the case, is complaining of constipation, like decreasing bowel frequency and bloating. So there is no concern of dry, hard stool. In that case, Docusate wouldn't be your best choice for this patient. The one thing I do want to point out is that even if the patient have dry, hard stool, generally Docusate is still used after your bulk forming agent. So that's why for most cases of constipation, your first line agent should be a bulk forming agent, unless the patient have, really for the most part, unless the patient have fluid restriction, because you got to take fluids when you take bulk forming agents. Okay. The last agent that was on the choice, or one of the choices, is mineral oil. Mineral oil is a lubricant, and generally at this point, we don't really use mineral oil for constipation anymore. So whenever you see mineral oil, chances are that even though it's a laxative, it's you're probably looking for better options there. Okay, so that's why the answer is polyethylene glycol. Any question about this question? All right, moving on. Second question is a patient who, again, comes in for constipation. You had initially recommended Cilium, which is a bulk forming agent. And you told the patient, when you were doing your drug counseling, that this drug can take up to 72 hours to work. Now your patient tells you that her last bowel movement was 4 days ago, and she's really hoping to buy something that would work in 12 hours. Which of the following would be the most appropriate to recommend? So, any idea?
Is it C, bisacodyl tablet?
That's correct. So bisacodyl tablet is the correct answer. And really, when you're actually out there, even though, we keep on talking about, right, like bulk forming agent really should be used as a first line agent and stuff like that. You might run into issue with like, it doesn't work fast enough. Generally, we would still recommend that, but then at the end of the day, there will be times where you have to recommend something that will work faster. So this particular patient is like, I really gotta go. It's been 4 days. I can't wait for another 3 days. That would be like a week. I mean, I guess it sounds kind of reasonable. I definitely, for a patient who's not, who kind of, we don't know exactly why the patient has constipation, but I certainly wouldn't like recommend bisacodyl or, something like that long term without trying a bulk forming agent. But if it's for like occasional relief, and then I would say, well, you can use bisacodyl. And then after you have the bowel, after you have the bowel movement, I still recommend that you take bulk forming agent along with your dietary modification and all those lifestyle modifications. Okay, so that's just kind of the clinical Pearl side. But for the exam, you have Marilax, Docusate, bisacodyl tablet, and mineral oil enema as your choices. Going back to your clinical Pearl slide, that we really should consider onset of action. And remember that we have bulk forming agents, Marilax and Docusate, though all three actually can take up to 72 hours to work, right? On the other end of the spectrum, you have suppositories and enema. really the enema we have is Fleet's enema, and the suppository that we have glycerin suppository. We also have Biscotto suppository. But those work within like minutes to like maybe suppository will take like an hour, but enemas really work within like a few minutes. So in the middle, when you're talking about like kind of like just like within a day or like within a few hours, you have oral lubricants, oral stimulants, and oral saline laxative. But oral lubricants are not really used anymore because we have mineral oil. And like I mentioned earlier, we don't use mineral oil much anymore. So really you're down to like realistically thinking about oral stimulants and oral saline laxative. And then you just have to remember that oral stimulants work a little bit faster than saline laxative. But both of them work, maybe 6 hours. Maybe oral stimulant more like 6 hours, saline laxative more like 12 hours or something like that. Okay. All right. Question 3, we're switching gear to a diarrhea question. MT is a 2-year-old boy. The patient is 31 inches long, weighs 29 pounds, who has been having 4 to 5 watery bowel movement every day for the last 2 days. MT has been crying a lot, but with decreased tear production. He also has slightly sunken eyes. Which of the following would be the most appropriate to recommend for the patient's diarrhea? So I guess just based on these, you know that the first thing you should do for diarrhea is probably consider oral hydration therapy, right? Did anyone actually do the calculation for this question?
It's A.
It's A, and A is the correct answer. For any kind of diarrhea question, if it's case-based, the first thing you really should is to assess the severity of dehydration, because as I just mentioned, the first thing you really consider for any diarrhea is oral hydration solution, because diarrhea is generally self-limiting, and going to the bathroom a lot doesn't really cause the fact that you have to go to the bathroom a lot, and while it's uncomfortable, it's not the most dangerous thing, like that the act that you have to go to the bathroom. What's dangerous is all the electrolyte abnormality and all the dehydration that it accompanies. So the first thing to do is to assess the acuity of, or I should say the severity of dehydration. So for this particular patient, the patient has been crying a lot, but with decreased tear production. The eyes are also slightly sunken, and the patient's been having, 4 to 5 watery bowel movement every day. So this really, everything lines up that this patient has mild-moderate degree of dehydration or mild-moderate degree of diarrhea. Then, once you figure out the patient's dehydration status, you can kind of figure out whether or not you need to have rehydration phase or just need maintenance phase. So rehydration phase is administered if the patient has mild to moderate dehydration. The idea of the rehydration phase is to quickly replace water and electrolyte deficit over 3 to 4 hours. Obviously, if the patient has no signs of dehydration, you don't need to give this extra water because there's probably not that much water and electrolyte deficit. If the patient has severe dehydration, then that's the basis for medical referral. That's why rehydration phase is when the patient has mild to moderate degree of dehydration, which this patient has. If you were to administer some fluids for the rehydration phase, then the next thing you need to consider is how old is the patient. Our patient is 2 years old, I think. 2 years old. So a dose to be given is 50 to 100 ml per kilo. Once you're done with rehydration phase, well, the patient is still having diarrhea, so we still need to replace all the fluid that's lost during those episodes. So after each unformed stool, if the patient is between 6 months to 5 years old, then you will replenish 10 ml per kilo of fluid, right? So that's if it's like a toddler. But then if the patient is at least 5 years old, then you will give 2 to 4 liters for rehydration phase if that is indicated, and then half to 1 cup of fluid after each unformed stool. Going back to this patient is 29 pounds. So the first step you do is convert pounds to kilo because the dose is based on ml per kilo. So this patient is 13.18 kilo. And then you will calculate the amount of fluid to be replaced, which is 50 to 100 ml per kilo over the first 3 to 4 hours. And that range, once you do the calculation, come out to be 659 to 1318 ml. And out of the choices that you have for rehydration phase, then 750 ml is the correct answer. Next, you move on to, oh, that's a typo. Next, you move on to maintenance phase, which is 10 ml per kilo after each unformed stool. Then you take 10 ml multiplied by 13.18 kilogram, and that gives you essentially 132 ml. You round that to be 130 ml, right? That's the answer that's given. So when you put everything together, you will give this patient 750 ml of oral rehydration solution over 3 to 4 hours, followed by 130 ml of solution after each unformed stool. Any question about this calculation question?
I did want to remind you all that for the final, you can use the calculator that Dr. Coomer allows for his calculation course. Because it sounds like there were some issues with using the calculator in ExamSoft, although that is still enabled for the final. If you will be using that calculator, make sure to show it up in your video so we can see that you're using it.
All right. I assume that we know what to do with rehydration. So we'll move on to the next question. This is a patient who come in with diarrhea. This is an adult and has been keeping up with fluid intake at home, but the diarrhea is really annoying. So this patient is trying to get something to decrease bowel frequency. So which of the following would be the most appropriate to recommend? Any thoughts?
Imodium.
Imodium. Yeah, the Imodium is the correct answer. This question, I would say, is pretty easy. It's obviously on the easier side when you talk about a case question. It almost doesn't need to be a case question, I guess, this particular one. A lot of this is really to test brand generic, so that's the one thing. You got to know your brand generic. What's the generic name for Imodium? Loperamide, right? Loperamide. Dulcolax, the generic name is Bisacodyl. That's actually a constipation medication, so that's not to be used for diarrhea. Pepcid, the generic name is Famotidine, and that is used for the treatment of heartburn and dyspepsia, also not used for diarrhea. Milk of magnesia is the generic name for magnesium hydroxide, which is also a laxative agent, right? So out of the 4 choices that's given, really only one drug is used. It's an antidiarrheal agent. So that's pretty easy as long as you know all the, the brand generic along with the indication. So at least for my section, I believe on your learning objective, if there is, so you may not need to know the brand generic for every single drug that's listed, but if it's listed on your learning objective, you gotta know the brand generic. Okay. Question 5 is really like a classification question again. This is a patient who presents with symptoms consistent with heartburn, and the patient has symptoms 3 to 4 times a week, and these symptoms significantly interferes with his normal activity. And how would you classify this patient's heartburn? Okay. And I would just tell you the answer. The answer is that this patient has frequent and severe heartburn. If you go to your lecture slide, you'll find that the classification slide, this patient has symptoms 3 to 4 times a week, and anything that's occurring at least 2 days per week is considered frequent. Okay. And in terms of symptom severity, the symptoms it's kind of more or less subjective, but this one I think is pretty straightforward because the patient is these symptoms significantly interferes with normal activity, and this would be severe heartburn. So taking it together, this patient just have frequent severe heartburn. Knowing classification is very important, I think, for my section, because a lot of my topics happen to start with classification. You got to know how to classify the disease before you can figure out what to give, right? Like for diarrhea, you need to figure out the dehydration status first. For heartburn, you got to come up with the heartburn classification first. For allergic rhinitis, you need to come out with, you need to figure out if it's episodic or, or persistent allergic rhinitis and the severity before you can select your drug. So make sure you know how to classify the patient, because if you can't classify the patient appropriately, even if you know kind of the algorithm on how to treat each of these classification, if you categorize it wrong, then you will kind of in the end get the treatment wrong. So make sure you know how to categorize the patient. Here we have the last question. This is a patient who presents to the pharmacy with symptoms of heartburn. The patient has been taking famotidine continuously for the last month, but his symptoms still have not gone away. Assuming that the patient has already implemented appropriate non-pharmacologic measures, which of the following would be the most appropriate to recommend? Any thoughts?
He needs referral because he's been taking the famotidine for like well over 14 days.
Very good, yes. So refer the patient for medical referral. That is the correct answer. And if you go to your kind of exclusion criteria slide, you'll see that, you know, their heartburn, I think, probably have the most exclusion that I box in. Because a lot of these are just alarming symptom, right? So really it's just like, you know, for heartburn, it's like alarming symptom, severe heartburn or dyspepsia, or if the heartburn does not resolve after 2 weeks of continuous treatment with a non-prescription H2 receptor antagonist or PPI. PPIs are taken continuously, right? So if you ever recommend a course of PPI, you should recommend 14 days of therapy. But H2RAs, really these are used as PRN, but this patient has to, you know, so if the patient uses a PRN like once a week, and the patient has been on it for 2 weeks, you don't need to refer them, right? It's like they really only took 2 doses. But if they use it continuously for 2 weeks and they, you know, heartburn still not going away, then that's time for referral. So 2 weeks is your magical number to remember. And I think that's all I have for, you know, for my section. So thank you, Yasser and Jason, for, you know, for your participation today. I know that not everyone might have like done these, so thank you guys for kind of still carrying the conversation forward. Any questions for me, for Dr. Ko, you know, about the exam?
Do we get scratch paper? I know you said that we can use a calculator, but
Yes, you do have access to the note taking. But not like paper and pencil.
okay.
Yeah, so there is the note taking function is enabled in ExamSoft. You can use a physical calculator because it sounds like there were some issues for some people with using the ExamSoft calculator. But you won't be able to use like a paper and pencil to like write things down.
Hi, Dr. Cole. Everyone mentioned that the TI-83 is allowed to use the calculator, but I have the TI-83. Is it okay to use this calculator?
I think the specific one is like TI.
30?
Yeah, let me, because Dr. Kumar said that one is a like programmable calculator. So only that one that he allows in his course will be allowed for this course too.
Yeah, I think the TI-83 is non-programmed too, I think.
I think 83 sounds like what I had when I was a student, and I think that's the programmable one. It's one of those big ones, right?
Oh yeah, the big one.
Yeah, the big ones are programmable.
Oh, okay.
So the TI-30X.
I see it's this. No, you can't see.
Can't see.
Oh, it's blending into your. Yeah, that one.
Oh yeah, Jason's.
That's it,
Yeah.
yeah.
Look at Jason's. That one showed up somehow because I guess maybe not virtual background or something.
Yeah.
Virtual background, like all I can see is like it just shines.
Your medications. Yeah.
Yeah.
Yeah, that's perfect. Yeah. So just right before you take the exam, just remember to show it so that we know that if it looks like you're looking down and like doing something, then we know that's why. Because exam monitor will like flag things that might seem like suspicious.
Yeah. Thank you.
It's $5 from Target.
Is it only $5? I would think it's
It's 15.
Yeah, it's
Yeah.
$5. I
No,
see I
it's
got
on sale,
$5.
it's 15. Target he went to.
Any other questions for us?
Target he went to.
It's kind of the same thing that I keep on saying. Make sure you know your generic brand and generic, so then you don't just like miss a question because you don't recognize the brand name. Make sure you know study the learning objectives, especially the ones that are specific. Try to go over the application question that the application that we went over in class, because those serve as good practice for cases. These questions, obviously, we just went over. Yeah. I don't really know if I have any other pointers.
Yeah.
But we have one of the Monday exam. I'm sure you guys will still feel refreshed when you take that exam. And then as the week goes on, it may get tougher and tougher.
Yeah, I think ours is the very first one because it's at 10. I think it's the first final that you have.
I'm sorry, Dr. Cow, I joined a little bit late.
Mm-hmm.
Is the questions you were reviewing from your slides or that's new questions?
Those are what Dr. Ko posted onto that practice quiz. So we just went over the 10 questions.
Okay.
I think Dr. Ko said we will be posting them. So if you want to take a look again, at least the correct answer will be, well, one is you can access through the quiz. And then two is that I believe the correct answer is also indicated on the slide deck. So then I guess you'll be able to see that as well.
So I just posted my part of the slide deck with my questions and like the slides that accompany them. They are posted right underneath the quiz at the very bottom of the Moodle page. And then if you go through, if you click into the quiz again now, starting at 4 o'clock, all of you should have been able to see which ones are the correct answers. So at least you know what are the correct answers to the questions.
Actually, Dr. Ko, on your slide deck, you did say there is the rationale portion. So then technically the correct answer is indicated, right?
In my slide deck that I just posted, I highlighted the correct answer, and I also, like, basically everything that I went through, I just posted.
Okay.
So it has the rationale, and it has like the slides that the answer kind of
Or the
refers
quiz.
to.
Yeah.
Mm-hmm. So it
Okay.
has all of that. Yeah. But I just posted my section of that.
Sure. I'll post my section now too.
Okay. But yeah, it's just at the very bottom where it says final exam, right underneath the quiz. We'll have our PDF versions of what we just went through there. So if you like want to look through and see why the answer is correct or incorrect, like that will be in the slide deck. But if you just want to quickly see like what was correct, what you got wrong, or what was correct, it is, if you click into your quiz, you should be able to see the correct answers now.
Sounds good. Thank you so much.
Right.
Yeah.
I think that's it.
Yep.
Thank you so much.
Reach out.
Thank you so much.
If you have any questions.
Yeah. Good luck on the finals week.